Hi, it's Professor Miller. This next lecture is going to cover information in Chapter 14, and it's mainly the muscarinic agonist and antagonist. Um, I didn't really like the PowerPoints that they had with the text, so I kind of went ahead and made an outline for you guys. And this is the stuff that I would like you to concentrate on for this information within Chapter 14. So let's cover a little bit and kind of move our way through. A muscarinic agonist or muscarinic antagonist, muscarinic is the same exact thing as a cholinergic, or an anticholinergic if you're looking at the antagonist. This is affecting the nervous system, the parasympathetic nervous system. So remember, in contrast to your alpha and beta, this is more of the muscarinic and nicotinic within the parasympathetic, or your rest or digest part of your nervous system. So let's first take a look at muscarinic agonist. There's not a ton of medications that we really use within this class. There's a lot, but the ones that are more common would be one like bethanechol, which is actually used for urinary retention. So thinking back, think about the muscarinic receptors and the parasympathetic nervous system. So if you're to turn on the parasympathetic nervous system, what happens? What happens when you activate those receptors? And that's kind of how you got to look at these drugs. With a muscarinic antagonist, so you're going to be turning it off, it's the opposite of what the parasympathetic nervous system would be doing. So right now we're looking at the cholinergic receptors with muscarinic, and these obviously have acetylcholine there. It works with the receptor. And now let's take a look at this. Going back at this chart that's in the Moodle book, it might be a little bit blurry, sorry, but we're looking at the parasympathetic right now. So if you're activating the parasympathetic nervous system, these are the end result that you end up with. If you have an antagonist, you're essentially going to end up with the opposite of what you see here. So first we'll talk about, when we talk about bethanechol, that's, like I mentioned, it's used for urinary retention, because it's basically a cholinergic agonist, which promotes emptying of the bladder. So that's the use of that medication. So it's basically working through the parasympathetic nervous system. Now let's go back to the other document. Okay, so as I mentioned, it's activating the muscarinic receptors in the urinary tract. We don't want to use these with patients that have had any recent surgery of the bowel or intestinal obstruction, just because it can activate those receptors within the bowel. And it would predispose them to like a bowel perforation. Another thing too, if they have a kidney stone or a urinary tract obstruction, you wouldn't want to use this either, because obviously there's an obstruction there that would inhibit the urine from coming out anyways. So you have to treat the underlying cause with that one. It may cause exacerbation of asthma because of the muscarinic activation in the lungs, because if you look back at that chart again, you'll see that the cholinergic drugs or muscarinic drugs can activate in the lungs. So it can exacerbate asthma. So like I said, exacerbation of asthma, it can cause hypotension or bradycardia, abdominal cramps or diarrhea, or it can even have dysrhythmias. And that's more common typically with a hyperthyroid patient, because they're already at risk for tachycardia as it is. So if you look at these side effects, it's because of where it's hitting at the receptors. If you're looking back at the parasympathetic nervous system, if it's turning it on, it can have these side effects that goes right alongside with it. So that's the one muscarinic agonist that I would kind of take a look at. The other one is pilocarpine, and this one's strictly used in the eye. It's an eye drop. It's used for the therapy of glaucoma. And glaucoma is where they have increased intraocular pressure within the eye. So pilocarpine will actually reduce the intraocular pressure within their eye. That's all you really need to kind of know about that one for the time being. Going down to muscarinic antagonists, these are your anticholinergic drugs. And you'll hear the word anticholinergic probably more often than you'll hear muscarinic. We always call them, oh, it's an anticholinergic medication, or it has anticholinergic side effects. And remember, these medications are the opposite of what the parasympathetic nervous system does. So this is going to be drying them out. It can cause constipation. Sometimes in the elderly, it can actually cause CNS issues like drowsiness or dizziness. It can affect the heart. So what this is doing is producing a blockade at the muscarinic receptors. It's essentially preventing that receptor activation by acetylcholine. Because remember, acetylcholine is the one that typically works within your parasympathetic nervous system. So if you know what the normal response is to muscarinic activation, you'll know what, like for instance, what atropine will result in, because, or the opposite of it will be what atropine does, because it's an antagonist. So a drug like atropine, it will cause an increase in their heart rate. It'll decrease the secretion from salivary glands, and that's where they get the dry mouth. And it also can decrease sweat gland production, so that actually will dry them out too. It can relax the bronchial smooth muscle, and it will also decrease the tone of the urinary bladder. So that's why a lot of those overactive bladder medications like Detrol or Enabalex, they are anticholinergic drugs or muscarinic antagonists, and it's because it decreases that tone in the urinary bladder. When you're looking at the eye, these antagonists or anticholinergics, it'll cause dilatation of the pupil. So sometimes you'll see atropine used to dilate the pupil for an eye exam. And that's kind of how it works. It works through the parasympathetic nervous system, or blocking it essentially. These drugs also can cause CNS effects such as excitation, like I mentioned. So the elderly population are more sensitive to anticholinergic medications. So we try to refrain from use with them. And if we do, we try to keep the dosing of it a little bit lower. So the one to kind of look at is atropine, atropine eye drops. We kind of, those you'll see, and we do use atropine too. Sometimes I actually use that with cardiac arrest because it'll bump up the heart rate. Other therapeutic uses, pre-anesthetic medications can also be used to control secretion. So sometimes they'll give it before surgery, and it'll decrease that amount of bronchial secretion. So it'll obviously help open up the airways with less secretions there. A lot of times it's not used that much because a lot of the new anesthetic drugs are, they have actually the capabilities of doing this on their own. Like I mentioned, it's used topically for the eye, for eye exams. It's used for bradycardia, and then it's also used for muscarinic poisoning. So if you have a toxicity of any of the medications that affect the muscarinic system, or a muscarinic agonist, atropine would be a reversal agent for muscarinic poisoning. That's a relatively rare thing, but just so you know, that's what it's used for too. So in the clinical setting, you most commonly will see it used topically for eye exams or systemically for muscarinic reversal, like I mentioned, or bradycardia. So sometimes if they need to bump up the heart rate more, especially like if they're using epi during cardiac arrest, that's the other option, and that's usually one of the things that they will have in a crash cart. Side effects for atropine, which would be the anticholinergic side effects. Dry mouth, blurred vision. Those are the common ones. You'll hear this a lot with any anticholinergic side effect. They can also have increased intraocular pressure, and that's important to kind of remember with the patient that has glaucoma. So just look at the opposite up here. If you're looking up here at bethanechol or pilocarpine, it's used to treat glaucoma. So it's going to basically decrease. This is going to decrease the intraocular pressure. But now, if you're looking at the opposite, an antagonist, it's going to cause an elevated intraocular pressure. So any patient with a history of glaucoma, we try to limit use of anticholinergic agents because it can worsen their glaucoma. Like those overactive bladder medications, we really do not like to use those with patients with glaucoma. These medications cause urinary retention, which is another anticholinergic side effect. However, we use this side effect essentially as a treatment. So we'll use it as a treatment for overactive bladder. Anticholinergics can also cause constipation, anhidrosis, because the ability to produce sweat is decreased. So that's essentially what all the anhidrosis means. It can cause tachycardia in the patient. And then it can exacerbate asthma because it basically and this is more because it dries out the secretions in their lungs, and this creates a mucus plug. So it's not necessarily affecting the actual airway. It's more due to the secretions. So when you're looking at these, look back at your parasympathetic nervous system, and essentially These agents up here are agonists, so it's going to be working like your parasympathetic nervous system. These agents are antagonists. They're going to be doing kind of the opposite of what your parasympathetic nervous system would do. Going down a little bit, the one class for muscarinic antagonists that I would kind of focus on besides atropine would be the overactive bladder agents. Overactive bladder is basically known as urge incontinence. It's where they have increased frequency, urgency, and then involuntary leakage. And this is common in women, especially as they go through menopause. The reduction in hormones and just the muscles supporting the bladder are weaker. So it's pretty common. So our whole overall goal with treatment is obviously to help this urge incontinence. So we'll use muscarinic antagonists or these anticholinergic medications to improve their symptoms. Now, when you're looking at the muscarinic receptors, you know how we looked at, for instance, if we looked at the sympathetic nervous system, we have the alpha and the beta, etc. Well, within the muscarinic, we have three different receptor subtypes. There's M1, there's M2, and M3. M3 is our target for overactive bladder. So we're trying to hit M3. M2 and M3 will exert an effect on the heart and the CNS. That's why a lot of times in the elderly population, that's another reason for them having the CNS issues with it, because they do get a little bit of that M1 receptor hit with it, or even the M2 receptor hit with it. So that's why we try to find the anticholinergic agent that works best that's selective to M3 as best as possible, essentially. Hopefully this is making sense. Because once you're hitting M2, M3, you're starting to hit other systems, and that's when you're going to get these other side effects. So if you actually look at table 14.5 in your text, you'll be able to see the list of agents, and it'll go through different ones. Like we have Enablix, or we have Detrol or Ditropan. Enablix is actually a really good one for the elderly population because it is very selective to M3, which is the one that we're targeting for overactive bladder. And they have less side effects with it. They have less CNS side effects with it. So I'm just trying to give you an understanding about selectivity and then overactive bladder and kind of the differences here. So then if you look at Ditropan, it's primarily M3 selective. So it does have a little bit of effects on other systems, but it is less but it's less than the non-selective agents that are out there. And Detrol essentially is one of these agents that's pretty non-selective. So they are going to have more side effects with Detrol. So if you have a patient that's having a lot of side effects with Detrol, changing them to a Ditropan or Enablix, they might do better on. Now, in terms of side effects for these medications that we use, a lot of them can complain of dried mouth, photophobia, or they can have blurred vision, tachycardia. They can also have urinary retention, so you got to watch and make sure they're not going the opposite way. Constipation's another big one, and then suppression of sweating. So you want to use these cautiously with other medications that produce anticholinergic side effects, which we'll talk about down the road. Antihistamines are known agents that have anticholinergic side effects, and these are like the Benadryl. There's a that's Elcrate. There's Benadryl, Claritin, Zyrtec. Those are all your antihistamines, but they have the same side effect profile of the dry mouth, blurred vision, and it can have urinary retention. So when you combine the two, obviously it's going to potentiate the effects of the anticholinergic side effects. Like I mentioned already, anticholinergic medications should also be used cautiously in patients with glaucoma because it can increase their intraocular pressure. So this is a good outline of where I would like you to focus with this information on the muscarinics for Chapter 14. The lecture, when I was going through the PowerPoints, I felt like it was a little bit too much, and I felt like this was a better way of getting you to focus on the specifics that I feel like you should know. So Bethanechol, just be familiar with it. Pilocarpine, just be familiar with like the muscarinic agonist class, like, you know, in how it relates to the parasympathetic nervous system. And then in terms of the antagonist, be familiar with atropine, and then also look at like the overactive bladder medications like I kind of have down here, and understanding selectivity with like M1, M2, M3. If you have any other questions, please let me know. I'd be happy to answer them or help you out.